this is where we would then take the next step. And I don't know, I think this procedure is become a lot more commonplace, but one of the things that, not me, but my interventionalist colleagues invented at Emory is something called leaflet modification. In the TAVR world, it's called basilica. In the mitral world, it is called the lampoon. And so what we would do in this case is we would actually go in, before we even put a valve in, we would actually go in, loop the anterior leaflet of the mitral valve, and literally splay it open. And if you splay it open, because if you put a valve in here without doing anything, you're going to have leaflet, right, on the outside of this valve, right? That's where this TAVR valve is going to sit in there. You're going to have leaflet covering that whole anterior side of the valve, covering up all of those open cells. If you lampoon or do some sort of leaflet modification and you cut open that leaflet first before you put a valve in, you could theoretically shorten it in half. And so that you can't get the valve any smaller. The valve only comes in certain sizes, but you can at least prevent the leaflet, the native leaflet, from covering up these open cells. And so the way that we would now measure your LVOT area is we would go and scroll down to the pink line, assuming that these cells are not open, and now we can measure this LVOT area. So if I do that real quick, 230. Again, a lot of things that would have to happen perfectly, right, to get to 230. But this is a case that I think if this patient obviously had no surgical options, that we would talk to them about how a lot of this stuff is off-label and at high risk, and some of this is not perfect science, but we would say that we could think about doing a valve and MAC with lampoon. So yeah, I think that's probably what we'll do for this lady. And then one last thing, I'll just show you this one. So this was a case, this is the last one I'll do for just as a show and tell. So this was a case of a patient who had a pre-existing surgical ring. We did obviously there's a valve that's already in there. That's actually what a sapien valve looks like in the TAVR valve looks like in the mitral position. And what you can see is, right, like this valve that's in there that we deployed is pretty dang close to that septum. Like this is someone that, you know, it looks like they probably were at risk for LVOT obstruction. And there are patients where they're high risk for LVOT obstruction. You do your leaflet modification with the lampoon, and that's still not enough room. So then what can we do? And so the second thing that was invented at Emory is something called a Sesame. I think we published our first Sesame paper maybe a year ago. But basically what it is it's a transcatheter myectomy, or I'm sorry, myotomy. Myectomy is a surgical term. So surgeons and patients who have hypertrophic cardiomyopathy will go in there and carve out the anterior septum to create room to eliminate LVOT obstruction. We are now doing that, but percutaneously. And we're not cutting anything out, so it's not a myectomy. It's a myotomy. We're doing the same kind of electrosurgery technique where we slice open muscle or leaflet or whatever it is. And what happens is that the muscle will also kind of carve out or splay open. And so what I wanted to show you is now, so look at this picture here. And you see this divot right here? The original septum probably was like this, right? That's probably, if you trace out the contour of the myocardium, was probably look something like that. But when we did the Sesame, we basically carved out this little dimple of space. And so I'll scroll through the base now. So you can start to see, you see that little dimple right there? And then it ends probably there. And so that is all what we created. We literally created more area in the LVOT. Now, is it a lot of room? no, right? Like if I were to measure this area here, my guess is it's probably 80 at best. But again, this person is alive because they had an additional 80 millimeters squared of LVOT room. I probably overdrew a little bit, 100, right? And that was the difference between life and death for this person. So my guess is they probably still had a residual gradient across their left ventricular outflow tract, but they walked out of the hospital. So that's a trade-off. I think that's all the time I have. And so again, this was more of a kind of show and tell. I think learn your coronary stuff, learn and get good at TAVRs, get good at appendages. That's going to be the bread and butter of what most structural imaging or most, I think, advanced imaging people will need to know how to do moving forward. And then the mitral and tricuspid stuff are probably the next level up. I think for our fellows, it takes them, depending on what their backgrounds are, it probably takes them 1 or 2 months to get good at the coronary and TAVR stuff, and then takes them another 3 or 4 months to get good at the tricuspid and mitral stuff. But anyway, if you guys have any interest in joining our program and learning more about this stuff, then let me know.